Ferrer, excuse me. Dr. Ferrer will then take your questions. As a reminder, to ask a question, please use the hand icon, or you may chat me, the host, Dr. Ferrer, when you're ready.
Thanks so much. Good afternoon. Thanks everyone for joining today's briefing. I'll give a COVID-19 status update for LA County and provide information on the direction the current surge appears to be headed. I'll take the first slide. While cases and hospitalizations remain elevated, we're relieved to see declines across both of these metrics. Today, we're reporting 7,009 new cases, with the average number of cases reported over the last week at about 5,900 new cases per day. That's a decent decrease from last week's average of 6,750. The number of COVID positive patients in LA County's 92 hospitals has also decreased, with 1,239 hospitalizations reported today. This is far fewer than the 1,329 hospitalizations that were reported a week ago. Among those hospitalized who are infected with COVID, about 43% are hospitalized with COVID-associated illness, 12% are in the ICU, and 7% are on a ventilator. The 7-day average test positivity rate has remained relatively stable this past week at slightly over 15%, a small increase today. Positivity rates statewide and nationwide are slightly higher at 16.4% and 17.3% respectively. We reported an average of 15 deaths per day over the past week. That's a slight increase from the average of 13 deaths reported per day last week. As a reminder, since deaths always lag behind cases and hospitalizations, slowing viral transmission will typically result in lower death rates a few weeks out. And I'll talk more about deaths in a minute. The next slide. The screen trend line shows average daily reported cases. As you can see, there has been a fairly steady decline in cases since July 23rd, potentially signaling the beginning of a downward trend in cases. We're glad to see this. It would be welcome relief if this current surge has peaked. Daily hospital admissions, shown by the orange line, have also begun to decline for the first time since mid-April. Since hospitalizations lag behind cases, it's reasonable to assume that the recent decline we have seen in cases will lead to continued decreases in hospital admissions over the next couple of weeks. Of course, although there's no way to predict the future, the case and hospital admissions data suggests that there is less transmission. The 7-day average number of deaths reported daily, as shown by the blue line, has slightly increased over the past few days. It's now at, as I said, I think it's at about 15 deaths reported per day. I do want to pause here and note that the most disheartening misinformation being circulated is the idea that almost no one dies from COVID now. This ignores the very real suffering and pain of those that are losing family members to COVID, and it ignores the brutal mortality rate that's still associated with this pandemic. The reality is that over 4,300 people have died from COVID in just the first half of 2022. That's more than the 6-month average total for deaths from drug overdoses, seasonal influenza, and motor vehicle accidents combined. As I mentioned a moment ago, throughout the pandemic, deaths have been a lagging indicator, with adjustments typically appearing weeks after we see changes in cases and then hospital admissions. If cases and hospital admissions continue to decrease, deaths, fortunately, are also likely to decrease a few weeks later. As always, for those who have recently said goodbye to a loved one because of COVID, we wish you healing and peace. Next slide. We continue to track the impact of the pandemic on LA County using the CDC's COVID-19 community levels framework, which CDC created as a measure of the strain on our healthcare system caused by COVID-19. The community levels framework utilizes 1 case rate metric and 2 hospital-related metrics, all of which are reported out by CDC once a week on Thursday. 2 weeks ago, on July 14th, CDC reported that LA County moved from the medium to high community level. And according to the most recent CDC calculations, and these are what got posted on their data tracker yesterday, we remain in high this week. CDC's, the first metric from the CDC framework is the 7-day case rate, which while still elevated at 426 cases per week per 100,000 people, is a welcome decline from the 481 per week new cases per 100,000 people that we saw last week. The first of the two hospital metrics is the 7-day total of new hospital admissions per 100,000. CDC currently calculates our rate at 11.5 hospital admissions per week per 100,000 people. Pretty similar to what they reported on Thursday, last Thursday at 11.7. The second hospital metric is the 7-day average for the proportion of staffed inpatient beds occupied by COVID-19 patients. CDC currently calculates this metric at 7.2%. This is the same as it was last week. Next slide. In the CDC's community levels framework, the hospital admission rate metric is the one that triggered LA County's move from medium to high 2 weeks ago, when it rose above 10 hospital admissions per week per 100,000 people. When it drops below 10 hospital admissions per week, that will cause CDC to move LA County back down to the medium community level. CDC's hospital metrics are shown on this slide, reflecting data for the 7-day period that ended July 25th. And we don't yet have more updated data from CDC. Therefore, since most of our local data trends have just begun to decline, we decided to take a closer look at the hospital admissions rate using our own data, which allows us to add a day, so that we could get a more precise sense of where we may be headed. Using the most current LA County data, we're able to look at the 7-day period that ended July 27th. And that's obviously more recent than the CDC data. As you can see in this slide, both the hospital admission rate and the percent of hospital beds with COVID-19 positive patients is currently lower than what's posted by CDC when we calculate these metrics using the more recent LA County data. Next slide. And you can see on this slide, because our own calculation does include that additional day of admissions data, there have been some small differences in the calculated rates over the past few weeks. And while these differences are not as noteworthy when we were experiencing an upward trend, they can make a significant difference when the admission rates are declining. And while we don't yet know what CDC will post with their update today, including their most recent hospital admission data, as you can see, when we use the LA County data on hospital admissions, we're moving from high community level to medium community level because our admission rate, calculating all the way through the 27th, is now 9.7 new admissions per 100,000 people. While we do need to wait for CDC to officially adjust the community level designation, and that's likely to happen next Thursday, we don't know today's data, but I think likely to happen next Thursday. Given the declines in case and hospitalization numbers, we're hopeful that the admission rate over the next few days remains under 10 new admissions per 100,000 residents, and LA County is soon officially moved by CDC to the medium community level. As I noted last week, any indication that the county would soon be moving to the medium community level would be a good reason to not move forward with universal indoor masking, which is what we are doing today. We will be pausing and not moving forward at this time. Next slide. Although we will not be issuing a new health officer order today to require universal indoor masking, the continued high rate of transmission does call on all of us to wear masks indoors in public spaces in order to help limit spread. As a reminder, masking is still required in many settings throughout the county, and that is not changed, and it's under the existing state and LA County health officer order. Masks are required in all healthcare settings, on public transportation, including buses and trains, and in transit hubs, as well as at long-term care settings, shelters, cooling centers, and correctional facilities. Masks are required for 10 days for anyone who was recently diagnosed with or exposed to COVID when they're around other people. And while we are still in this surge, indoor masking is very strongly advised everywhere else, in shared office spaces, in other work settings like manufacturing, in retail settings, whether you work there or you're shopping there, indoors at schools, and when you're in any indoor space, unless you're actively eating or drinking. As a reminder, businesses and institutions are always permitted to require indoor masking while people are on their premises, and this does remain a sensible action to take during times of high transmission. Next slide. There are a number of resources available to help guide you on information about masking, ventilation, and other COVID safety measures. Our website offers a detailed guide on which masks work best and how to obtain the best fit, and includes guidance from the state on masking for children. Small businesses and nonprofit organizations can obtain free masks, respirators, and hand sanitizers from PPE Unite. You can find them at ppeunite.org. We have guidance specifically for businesses, which includes signage that you could download and post. And there are also COVID-19 toolkits and sector-specific guidance that's available on our main webpage at covidph.lacounty.gov/coronavirus. Next slide. I do also want to provide an update on some of the other metrics we routinely follow. While our 7 early alert signals are all at the same level of concern this week as they were last week, I want to highlight a couple of areas where there's been a few changes. We are encouraged to see the decrease in the numbers within 4 of the 7 signals, including the percent of emergency department visits that are COVID related. Those decreased slightly. The case rate in the lowest income areas decreased over the past week from 351 to 333 cases per week. The number of outbreaks per week in settings for people experiencing homelessness also decreased from 19 to 12. And the number of worksite case clusters per week declined from 429 last week to 399. We did see increases in 2 signals, an increase in the percent of BA.4 and BA.5 cases, and a small increase in the number of outbreaks at our skilled nursing facilities. I'm going to review several of these signals in more detail on the following slides. I'll take the next slide. The Omicron variant, as you can see here, continues to account for 100% of sequenced specimens. The BA.5 and BA.4 subvariants of Omicron, they're shown in the red sections at the top of each bar on the right, continue to be of high concern because both of these subvariants have an ability to evade prior immunity. They're more infectious, and because they're evading prior immunity, they can reinfect people who were infected with other Omicron subvariants. In the week that ended July 9th, BA.4 and BA.5 combined accounted for 81% of all specimens sequenced. This is an increase from 62% just 2 weeks prior. BA.5 is now clearly the dominant variant, comprising 71% of all sequenced specimens. In comparison, as you could see here, BA.2, .12.1, those are the orange bars, now is only accounting for 16% of sequenced specimens. Only 1 specimen tested positive for the BA.2.3 variant. That's that sliver of a yellow bar. So it appears that this variant has been crowded out and no longer accounts for any meaningful percentage of circulation. The CDC estimates that across the country, as of the week that ended July 23rd, the BA.5 subvariant accounted for just under 82% of specimens. This is a jump from the 67% that was seen 2 weeks ago. Please note that the new sublineage of Omicron that's called BA.2.75, which has been spreading primarily in India and which also has an ability to cause reinfections, has increased just slightly this past week in the United States. It doesn't appear to be spreading rapidly here, and this is a trend we hope will continue. So far, there have been 35 cases detected in the United States and 9 in California, with 1 case in LA County. We will continue to monitor this new sublineage. The ability of the BA.5 subvariant to evade prior immunity and cause reinfections does remain concerning, and it's one of the key reasons for folks to wear masks indoors and take other precautions. As we discussed in detail last week, every infection creates a potential chance of experiencing not only immediate symptoms from COVID, but long COVID and repeat COVID infections can also increase the risk of other serious health conditions for some, such as heart disease, lung disease, blood clotting disorders, and diabetes. More studies are needed to truly understand the risk for both of these conditions. In the meantime, given the unknowns, we strongly recommend taking steps to avoid getting infected. Next slide. On this slide, the blue line shows the 7-day rolling average percentage of emergency department encounters which were COVID-related between March 1st and July 24th. As we've mentioned in the past, we monitor ED visits for COVID because it's a good way to better understand the impact of COVID on our entire healthcare system beyond just what's happening at our hospitals. And it also gives us a sense of the numbers of people experiencing illness significant enough to seek medical care. Throughout this late spring and summer surge, we've seen an overall steady increase in the percent of emergency department visits for people needing medical attention for COVID. However, in the past 2 weeks, there's been a leveling off right near the threshold between medium and high concern, followed by the slight decline. Specifically, this week, slightly under 10% of ED visits were COVID-related, and that's lower than the 10.3% from last week. Next slide. The trend line for the 7-day cumulative case rate for the lowest income areas in LA County between March 1st and July 21st of this year, as you can see on this slide, declined about 15% from its peak on July 18th. While the decrease is slight, when combined with the decreases we're seeing among other signals and metrics, it does provide additional confirmation that we're starting to see less spread. Next slide. Today, I'm also sharing data from the two largest wastewaters of the 4 wastewater systems that we monitor for the virus. Viral concentration data from the Joint Water Pollution Control Plant is shown on the left. This is the plant that serves the southern and eastern portions of the county. And the viral, I think that's about 3.5 million people. The viral concentration data from the Hyperion Water Reclamation Plant is shown on the right. This plant serves a large area in the city of LA. Combined, these 2 sewer sheds serve about 7.5 million people in LA County. There's a delay this week in receiving data from the other 2 smaller plants in Lancaster and Calabasas, so we'll share them next week. For both these plants, the white trend line shows the 10-day rolling average for viral concentration in wastewater. The dashed blue line shows that 2-week average for each plant between June 1st and July 22nd, 2022. And the dashed yellow line indicates the level that would be a doubling of the 2-week average. As a reminder, we do just compare the trends between the wastewater treatment plants and not the absolute viral concentration numbers because of the way in which viral concentrations is measured differing across the wastewater plants. You can see that for both systems, while viral concentration levels remain high, there's been a recent plateauing at the Hyperion plant and a slight decrease in viral concentration at the Joint Water Pollution Control Plant. Next slide. I thought today I could share a graph that demonstrates changes in the correlation between cases, that are reported to us and wastewater viral concentration over time to show the utility of monitoring viral concentrations in wastewater, especially during times like now where many test results are not reported to public health. The yellow line on this table shows the viral concentrations in wastewater from the Joint Water Pollution Control Plant. And the gray shaded areas show the daily case counts in LA County by episode date. As you can see on the left, during the winter Omicron surge and into the spring, there was a very tight match between the 2 metrics, providing us with assurance that monitoring wastewater viral concentration trends does provide fairly accurate information on the level of transmission in the community. As we began the spring and summer surge in May and June, wastewater data appeared to be indicating greater increases than the daily case counts were reflecting. Based on the prior close correlation in the trends, this discordance supports the reality that recent reported case counts are likely underestimating the true magnitude of community transmission. and this likely reflects both reduced PCR testing and the greater use and reliance on over-the-counter tests, which, as we all know, are not reported to the Public Health Department. Given the current discordance between the testing data and the wastewater concentrations, it does remain important that we're able to continue collecting the data from the test and monitoring those trend lines, but also monitoring wastewater as we move forward. Next slide. Work sites do continue to be places where significant viral spread occurs during times of high transmission. In this slide, the pink line shows the trend for the number of case clusters at work sites reported per week since the beginning of April. Similar to other metrics, we're seeing some declines in reported clusters, dropping to 399 cluster reports received this past week, down from 429 the prior week. It is too early to know for sure if this decrease will be sustained. However, when viewed in combination with our other data, we are hopeful that it will continue. Next slide. High community transmission, as we've noted in the past, takes the worst toll on those most vulnerable, including residents living in nursing homes and those experiencing homelessness. The purple line on this slide shows the trend for outbreaks in skilled nursing facilities, and the green line shows the trend in settings for people experiencing homelessness since early April. Since the beginning of June, the weekly number of outbreaks at skilled nursing facilities has repeatedly signaled high concern, and it does continue to do so now, with 37 outbreaks open in the past week. This is actually a small increase from the 33 we reported the prior week. While outbreaks in settings for people experiencing homelessness decreased this past week, they do remain concerning, and we thank everyone providing support to those experiencing homelessness. Next slide. We're gratified to see the improvements in our metrics, and we appreciate all those whose efforts continue to provide protection to those most vulnerable, since, as it has been in the past, the surges have the most negative consequences on those who are unvaccinated, older, have underlying health conditions, live in communities with high rates of poverty, and have more exposures at work and in the community. As we are hopefully moving to the medium community level, we'll need to continue to use common sense safety measures to reduce community transmission to a level that causes less disruption, less illness, and less death. We have great tools, and I'm glad that we're able to use them. So we ask that people please be up to date on your vaccinations to reduce your chances of severe illness should you get infected. Wear a mask when you're indoors to reduce the spread of an infectious agent at its source, while also protecting the wearer from aerosolized virus and respiratory droplets. Outside, remain safer than inside, and when inside, maximizing ventilation can help bring in fresh air and reduce aerosolized spread. Testing is the best way to know your status and prevent unintentional transmission to others, and we should get tested whenever we feel sick, have been recently exposed, or before attending gatherings. And for those who end up infected, swift access to therapeutics can make a big difference in preventing severe illness. In closing, as we move forward these next few weeks, I'm grateful for those who every day continue to take measures to protect themselves and others, layering in more protections when transmission risk is greater, and doing what they can to prevent spread. As COVID continues to be a leading cause of death, these efforts make a difference, and they do help those most vulnerable avoid the worst outcomes from COVID. Thank you, and now I'll take your questions.
Thank you so much, Dr. Freer. As a reminder, if you have a question, please use the hand raise icon. It should be at the bottom of your screen, or you may chat me, the host. Our first question comes from Ron Lynn at the LA Times. Ron, you're unmuted. Please go ahead.
Hi, Dr. Ferrer. Thanks so much for answering our questions. We really appreciate it. First, why do you think cases started to flatten last week? Do you think more people were masking up or moving gatherings outdoors, or do you think it was more that BA.5 was running out of people to infect? Second, a crystal ball question. Is there still a possibility that you would be in a position where we might face a mask mandate next week, or is that completely off the table given, I mean, are you using your own calculation that we're below 10 new weekly coronavirus positive hospitalizations for every 100,000 residents? And so the clock has stopped, so to speak. And then finally, going forward, are you still going to retain this, depending on your previous answer, will you still retain this framework of going into a mask mandate if we're in the high COVID community level for 3 consecutive Thursdays, or are you planning to reconsider that? Thank you.
Yeah, thanks so much. Ron, let me just write down the last question. I think these are all great questions. Cases did start flattening last week. Anecdotally, we hear from various people, and we have seen more people obviously putting on face coverings and being more careful. I think, in fact, that probably reflects the reality that so many people have been getting sick, that it's really touched many of us because we have family members who are sick or people in our social circles who are sick. So I think, the reality of what it means to have high transmission is increasingly brought home to many people. And there's still, many people who, when faced with that increased risk and knowing about that increased risk, are going to go ahead and mask up and take additional safety measures. I don't think it's just masking. I think people were also reducing risks in other sensible ways, as was appropriate given their particular situation. I was actually talking with the state about whether or not we think, BA.5 has kind of like run its course and has less and less people to infect. The models are all over the place. Some of the models that the state shared with us show just, a little bit of an increase or some plateauing. I think it's hard to tell with the subvariants at this time, because it really is hard to actually know whether our how on top of timing is the sequencing data. Like I always say, our sequencing data has a 2-week lag, and a 2-week lag is pretty important. So we're always kind of behind on recognizing how much spread BA.5 has been causing or been responsible for. One thing for sure, it's really crowding out everything else clearly, both here and across the nation. Whether it's run out of people to infect, I don't know that we can tell that for certain. What we do know is it remains highly infectious. So I would strongly advise that everyone keep their masks on when there's risk for that spread, because, as I noted on Tuesday, our chances have gone way up. In a group of 50 people, it's very likely that you have a 60% likelihood, 70% likelihood that someone in that group is infected. So, again, high rates of transmission still mean we should be very careful, but it could be a combination of factors that's leading to the flattening. People taking extra precautions or additional safety measures, as well as BA.5 is kind of peaked in terms of how many more people it can find, and that's going to help us. Really, for us, we want to slow the spread. We don't necessarily want to plateau. I mean, we need to see a decline. That definitely helps us get in better shape as we're all getting ready to welcome students back at school. Yeah, I loved your question on, did the clock stop or pause? The clock is stopped at the moment. I mean, I'm not calling it a pause, because our data indicates right now that, we'll be moving shortly back into that medium community level, at which case, since we've been adhering to the CDC framework and their guidance that when communities are at that high community level designation, they implement universal indoor masking. If we're not at the high community level, then, and we're moving back to medium, then again, aligned with CDC, we move back into strongly advising people to go ahead and wear those masks when they're indoors. I think the third question is really important. Are we going to reconsider how we use the framework? We're always sort of looking at the utility of any of the frameworks that we use, and this framework is no exception. I mean, many folks have noted, earlier that we were asking a lot of questions when CDC set up this framework about the distinction that's being made by the rest of us in calculating incidental hospitalizations versus hospitalizations for people with COVID. And this framework doesn't reflect that. And that's an important consideration, certainly for us, if this framework is going to continue to really reflect the possibility of increased strain on the healthcare system. So, I don't want to say definitively that we are reconsidering how we'll use the framework, but I do want to note that I think we, like all other public health folks across the country, are constantly adapting the frameworks. I mean, we've changed frameworks numerous times in recognition of sort of the changing trajectory of the pandemic, and I assume that remains for all of us an area where we'll continue to be mindful of what the data tells us as to what are the most helpful frameworks for us to use as we assess how to keep each other safe while we still have a lot of virus circulating. So thanks for those.
Our next question comes from Christine Maidu from the Wall Street Journal. Christine, you're unmuted. Go ahead.
Hi, Dr. Ferrer. Thanks for taking the questions. Just to be clear, so, I mean, given that we are in the third week of high community levels with the CDC, what you're saying is that upon taking a closer look for data that is 2 days later than the federal data, that you used that LA County data to base your decision to pause, as you say, moving forward?
Yes, I mean that you captured that well. Thank you for doing that. We do believe that that's why one of the reasons why I showed you that table that shows what this has looked like over the last 3 weeks, is there's always been a little bit of a gap. So we don't have the numbers yet for this week, that we'll get later today, but we anticipate because this trend that you're seeing isn't an anomaly. Like all of our metrics are moving in the same direction. So we do anticipate that CDC, because their data is a little older than ours, not as recent, once they catch up and they make their adjustments, they adjust every Thursday. So we're feeling pretty confident that we should be in that medium community level next Thursday. Now, obviously, there have been times where we have seen declines only to go rapidly back up again. That's why we're trying to really look at all of the data trends. Since all of them are moving in the same direction, I think it's a good sign that that's not what we're about to experience. But should things change, we'll revisit this decision, obviously. I hope that helps, Christine.
Our next question, I apologize. Our next question comes from Margaret Carrero at KNX. Margaret, you're unmuted. Go ahead.
Yes, fantastic. Dr. Ferrer, can you hear me?
Yes, I hear you great.
Okay, great. Just wanted to ask, kind of dovetailing off of that last answer that you gave about the idea of, looking forward, and you may revisit this decision if things change. Would you also maybe reconsider, I know it was brought up during the Board of Supervisors meeting, the idea of perhaps, just adding different sectors like grocery stores or pharmacies to an indoor mask mandate as opposed to a complete universal indoor mask mandate if it moves in that direction again?
Yeah, thanks, Margaret. It's a great question. And, we welcome the suggestion from the supervisor on this. We have asked County Council to help us determine how we would do that and not be subject to some legal actions. It's always difficult to actually apply one set of standards to one set of businesses or locations and not another. In the past, it's been easy to do based on sort of different risk levels of activities. It's be a little harder this time, that mostly was about, things staying opened or closed. But we have asked County Council. I think it's a great idea for us to look into. I'm just not sure whether or not we'd be able to do it.
Our next question comes from Howard Bloom from the LA Times. Howard, you're unmuted. Go ahead.
Hi, I have two questions, school related. So although antigen tests are inexpensive, school districts have expressed some concern about the availability and cost of these tests over the course of the school year and whether or not they will be provided free of charge and by whom as their COVID funding expires or is put towards academic recovery. What would you say about these issues? That's one question. And the other is, what would you say to parents about how this school year will be similar or different from the previous one? Thank you.
Yeah, thanks so much, Howard. We've been working really hard with our partners at the LA County Office of Education and also with all the school districts to address issues around the availability of antigen tests. I think we feel very secure saying that school districts will start the year with ample testing to cover what we call response testing. It's very important that every district be able to respond to outbreaks, folks who get exposed at their sites, testing requirements that Cal OSHA asks schools to adhere to for their employees. So we have to make sure that schools are well positioned to do that response testing. And I feel pretty comfortable that there's not going to be any issues when schools reopen this fall. And we'll have, and we're making sure that schools will have what they need for these initial couple of months. I think the question is a question of, what happens in the future? And are we going to get more funding that we'll be able to use or allocate to the schools? And how much support we will be able to get from both the federal government and the state government that have helped all of our efforts today around testing. I want to give a lot of thanks to the state and federal governments for their help with this because they have been amazing partners on getting us to a place where, up till now, there's absolutely been no issues at schools accessing testing capacity. So I'm hopeful. We know it's a pressing problem. I think we've worked it out so that schools can open with a lot of safety and have access to all of those testing resources when they open for the first couple of months, but we do need to figure out the sustainability of testing. Second question about parents. I'm always grateful for all of the love and support that parents give their children so they can be successful. And I know that makes a big difference in what happens over the school year. So, first, big shout out and thanks to the parents. I do think this will be an easier school year. I don't foresee at this point that we're anticipating there would be massive school closures. I think, as always, with the uncertainty of this virus, with its ever-evolving nature and the many mutations, we have to be prepared for the unexpected or the unanticipated, and that includes parents being prepared. But I'm hopeful that we open, that schools are full, that students feel welcome, that staff and teachers feel well protected and supported, and everybody can do their best to really make sure children are in a wonderful and enriching learning environment. So that's our intent. I've said all along, we share with everyone else the priority for children to be in school and to create as much safety as possible at those schools. I think that's our commitment moving forward. Thanks. We can take the next question.
Our next question comes from Jackie Poitier from KPCC. Jackie, you are unmuted. Go ahead.
Hi there. Thank you again for taking our questions. I just want to be clear. You went over this a little bit earlier, but I understand that we're on the cusp of going into the medium community risk level. but we could go back up. So just to be clear, under what circumstances would you reinstitute a public indoor mask mandate in the future? Thank you.
Thanks, Jackie. Great question. We're on a decline right now, and it would be hard. It's hard for us to imagine reinstating universal indoor masking when we're on this significant of a decline. But you're absolutely right. Should we see another big increase in cases and increases in hospital admissions, which we don't think is likely for the very immediate future because of the trends we're seeing, but could happen a week from now, we would have to go back and reassess whether we are resetting the clock about needing to remain in high, or we're going to use some other timetable. I do want to say, CDC continues to note that for communities that are in high, universal indoor masking is very appropriate. So again, we're asking people, since just as you noted, we're on the cusp. We think we're really going to see a movement into medium. We could use all the help we can get on that. Let's not depend on, sort of the virus is burning itself out. That hasn't really worked that well for us before. I think there's an opportunity for people to continue being safe, layering in protections, caring about what happens to the most vulnerable, putting on these face coverings, making sure that they're well-fitting and they're high filtration, so that we can continue to see the trend that we're seeing now. I mean, it's going to take all of us to continue to work together. So thanks, Jackie.
Our next question comes from Marla Tejas from Fox 11. Marla, you're unmuted. Please go ahead.
Hello. Thank you for taking our questions, Dr. Ferrer. So obviously there's been so much buildup to today's announcement. On Tuesday, you made a really strong pitch for masks. That was in your presentation to the Board of Supervisors. In that, you also noted that you've received, as they have, at least several of them anyway, a number of emails and calls from residents opposed to the mandate. So I'm wondering, how much did that public pressure, both from residents and notably from two supervisors, play into your decision today? Or is this solely based on the numbers?
Thanks so much, Marla. A really important question. So first, I do want to thank all of our residents, who express their opinions, who are very respectful in letting us know what's important to them and how they feel. I also want to note that this is a community with a lot of diversity, and I've received lots of emails and had lots of conversations with folks who are in favor of universal indoor masking. And sometimes those voices, get buried. So I do want to note that we've heard a lot from many, many people, and that I always welcome people, making sure that we're aware of their thoughts. And I particularly want to thank the folks who were very respectful in letting us know what their thinking was and how they were looking at the issues. I also want to note that the reason I focus so much on the data is it's really important to understand what's happening, not just at the individual level, but across our community. And that this decision, as I noted on Tuesday and as I noted last Thursday, would be based on the data, because we are still using the CDC framework for assessing what actions we will take as a community, depending on the level of the community level that CDC assigns us. So I feel pretty comfortable. The numbers don't lie. I've shown you today sort of trend after trend after trend. And I also noted, even on Tuesday, we were starting to see this of a decline. And it's a significant decline around hospital admissions, which actually tend to move a little quicker than the hospitalization numbers. I also looked those people who are hospitalized over the past 2 weeks, the length of stay did lengthen from 3 days to 4 days. So it explains a little bit. Again, hospital admissions tends to be a number that will change more quickly. and is based generally on a direct relationship with what we're seeing with transmission. So I feel pretty confident that, we are going to be able to move to that lower, medium community level, and that's a good reason, as I noted, really for the last 2 weeks, for pausing. I mean, it would be a little bit ridiculous to, go ahead tomorrow and implement universal indoor masking if I know that a few days from now we're going to be moved back to medium. Whenever we make changes in health officer orders, we spend a lot of time working with our businesses and our community-based organizations and our partners to provide education and technical assistance. We never start with citations. I mean, compliance has never looked like that for us. So rather than, moving people back and forth, I think given the data that I shared today, it's a sensible place for us to be, to not go ahead at this point and implement that universal indoor masking. Thanks, and I'll take the next question.
Hi, Dr. Ferrer. Our last question in queue comes from Bill Schuman at Fox 11. Bill, you are unmuted. Please go ahead.
Hi, Dr. Ferrer. Thanks. I know that you have your mask on today. You didn't have it on last week.
Well, it depends on who's in my office with me.
Okay.
So let's clear that up for a second, just so that people stop, sort of not understanding. We have a masking requirement here at the Department of Public Health. I'm always in my office when I talk to you all, always. If there's anybody in with me, which usually means there's a tech person here because I have tech issues, my mask is on and their mask is on.
Okay, great. Let me follow up with my colleague Marla Tejas' previous question, which you did not answer. I'll make it simpler for you. What percentage of your decision was based on the statistics you've cited, and what percentage was based on public reaction against universal indoor masking?
Well, I'm not sure there's a percentage here. We made our decision based on the data. I think that probably is the best answer. I want to thank everyone for joining us today. Obviously we didn't get to your questions or you have additional questions, please feel free to contact us. As always, we appreciate everything you're doing to keep the public well informed, and we'll talk again next Thursday.